Okay, hello, Goldie surgeon. So I'm going to be demonstrating how to do a chest drain insertion today. That's an intercostal chest drain. So firstly, you've got to establish it's the right patient. We've got the right need for a chest drain and a correct diagnosis. So we'll go through that in the lecture as to why patients would need a chest drain. Once you've done that, you talk to the patient if they're awake and able to listen to you. So explain to them what you're about to do. You've got sterile conditions as much as possible. I've got full PPE on myself, sterile conditions, and I've got some assistance, some help, and always explain to the patient what you're going to do, because it's obviously quite, potentially quite an anxious time for them to understand what you're going to be doing. And while you're doing that, and at the same time, you need to know what kit to have. So you establish the diagnosis, explain to the patient, and then the kit is important because you don't really want to not have the kit halfway through. So if I can go through the kit, firstly, you need to make sure the patient's not got any allergies. And if they haven't, that's great. If they have, you need to be appropriate. You need some local anaesthetic in a syringe, green needle, something to clean the skin, spare needle, an introducer or needle holder, another spare one of those, forceps, and also suture, scissors, scalpel, and this is a chest drain. So this is how the chest drain comes. Comes in this big packet. This one is a 28 French. So 28 French means the size of it. So they can be bigger, so 36, 32, 34, etc., etc. This is out to sheath, and then it comes like this. So the little cap on there, and then it's this. So basically this keeps it nice and straight in the packet, but inside is this spike, basically. So this spike is really dangerous, it's really sharp, so that shouldn't be anywhere near the patient at all. It's basically kept in there to keep this straight and not so floppy, but once you've seen it, it goes straight into the sharps bin and nowhere near the patient. So if you imagine this into the patient, or actually to use this to keep this tube rigid, then actually it can cause quite a lot of damage already in an unwell patient. So this tube then is what your chest drain tube looks like. So it's very floppy, it's got markings on it, it's got 3 holes on it. So the holes are one at the end and then 2 more. And then they've got these markings to make sure that it's actually in the patient for deep enough. If it's too superficial, it can fall out, and also it can cause subcutaneous emphysema in the patient's axilla. So make sure this is in the right place, make sure all this is okay, and you're happy with that, happy with the size, it's not damaged. But just to explain to you, if you get it in at a deep angle or wrong angle, this can easily occlude. So you may think the chest drain is in, but it won't work because you actually cause a big occlusion. So just be careful of how you put it in compared to the rib cage. So that's there. Then I need to check for the underwater seal system. So ideally, this should already be filled with water. So you fill this up with water. So when the patient's chest drain is in place, you can see what comes out. So what comes out will probably either be air, big gas, or could be liquid, potentially blood. And if blood comes out, you need to know how fast this fills up, and actually what rate, if there's any bubbling from there, etc. And also, if you imagine this as a pipe system, then if it's held above the patient, then all of this potentially could siphon into the patient's chest cavity. So once it's attached to the patient, this has got to be onto the floor below the patient, and then that's safe, and then you can do that. So that's got to be sterile as well. I'll just put that here for a second. Okay, so I've got all my kits. Again, I want to talk to the patient. The patient's arm position is very critical, so that's got to be basically touching the back of the head so that the axilla is exposed. I will show you a diagram of that. And once that's done, the patient's axilla is exposed, you're going to the 5th intercostal space into the anterior axillary line, so approximately the same level as the nipples, and that's where it's going to be. So here there's already a cut showing the right, showing the position, but I'm going to just make another demonstration here, and this is local anaesthetic. So again, explain to the patient, I'm making a skin bleb, making it nice and numb, and then go down deeper into the layers, aspirating first, and you're going above the rib, above the 5th rib. So you're avoiding the neurovascular bundle. So if you go in and you actually hit the neurovascular bundle, then potentially it's really dangerous. So the neurovascular bundle runs below in a groove below the rib, and if that's damaged and you convert to somebody who needs a chest drain, and are unwell, they could have a pneumothorax or hemothorax into somebody who's actually got more blood in there, so another hemothorax. So that would be potentially quite dangerous. So as you're going in, you're aspirating to make sure, and then you're infiltrating as you get deeper, and you're infiltrating into the intercostal muscles, and then into the just above the ribs, so actually into the periosteum, and then you should feel a little bit of a pop as it goes into the chest cavity. Now you're doing this and you're expecting the lung to be away from you, so there should be space, in which case you can aspirate and then get air, hopefully, or blood, and then you can put more local anaesthetic into that zone. So you have the area nice and numb, you take out the needle and the syringe, and then you pop it away into a sharps box, and then you've got the area ready. So next is the time to make the skin incision. So this is not the Seldinger technique. So Seldinger technique would be, you do this the same, but you're actually doing it with a Venflon, and you do it with a Venflon, and then you can insert the guide wire inside there, and that's what you can do in the medical scenario. But for an intercostal drain, which is what I'm explaining today, this is a formal chest drain that you'd use in trauma. So for this, you need a bigger incision. So get your scalpel and make an incision just like that. So make sure it's quite a broad incision, because you need not just your chest drain in place, but also your finger to do a finger sweep. And make sure you're explaining to the patient, making sure the patient's got some support, and someone else to reassure them if appropriate. Okay, that's in place. And once that's gone through the skin, you can go through some deeper layers, but you then do some blunt dissection with the grasper here, and making sure that you're deep. Again, you may feel a pop, and you're going deeper, and then you're expanding this this pathway really. So you're making sure it's the right direction. So it's quite easy to lose your way around in this area, especially if the patient's got larger body habitus. So if you're going in that way, you need to remember that way and not do your next pass here, there, or the other ways. And you always got to remember your neurovascular bundle so it doesn't bleed too much. So once you've done that, this is the trocar that you want to avoid. You pick up your chest drain. And what I'd recommend is that you go into the, there's one hole nearer the tip, and then there's a second hole which is further away, and you use that basically to put it in, and that just stabilizes the tip. So without that, it's too floppy to go in, and it'll just flop around and potentially even curl over. So if you do this, it keeps it nice and straight, and gives you some support, and better than your fingers going in, okay? So in it goes, you stabilize the patient, explain to them what you're going to do, and you slide that in. And before you actually breach the chest cavity, you clamp off the bottom end so it doesn't go everywhere on your shoes, for example. In you push it, and if you imagine you're pushing this into a patient, you need to go posteriorly, because that's where blood will be, and slightly towards the apex of the lungs, so that when they sit up, you'll be able to catch any air for the potential pneumothorax. So this is in place. Keep this here, and then that's when you attach your underwater seal. So it's got water in place. I put it below the patient. And under sterile conditions, I attach this, keeping this in place, making sure that the markings aren't coming out and becoming dislodged, and I open. And this is when the chest drain, if it's in the right position and the right diagnosis, it will start to work. So you'll get potentially blood, or underwater seal will start bubbling if there's air inside. And if there is blood, we need to know how much blood is being produced, how fast it's being produced, assess the patient again, do an ABC assessment again, stabilize the patient, explain to the patient, suture it in place so it doesn't move, and make sure that the patient's got oxygen on. Take a chest x-ray to check the position, and make sure that everyone is told that this underwater seal can't be lifted on top of the patient, for example, and while they move to the ward, for example. Once you've done that, then you can reassess, see what other injuries are involved, and then see if this is successful placement. Now, once the patient's on the ward, depending on what the diagnosis is and other injuries, that will determine how long this chest drain stays in for and what you need to do next. Okay, thank you.